بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we are continuing the lecture of imaging of cerebrovascular lesions and trauma in the pediatric age group, and we have finished the first part of this lecture where we discussed the diagnosis of hypoxic ischemic encephalopathy, and we discriminated between those lesions occurring in the preterm newborn and those occurring in the term in the full term newborn. Then we discussed the non-accidental trauma, and we emphasized the issue of the shaken baby syndrome. Then we are going to discuss now the traumatic cerebrovascular injuries, and these include the skull fractures, cerebral contusions, epidural hemorrhage, subdural hemorrhage, intracerebral hemorrhage, brain edema, diffuse and focal, and finally we'll talk about the diffuse axonal injury. And actually the vascular lesions we have discussed in the topic of intracranial vascular lesions presented in the series for adults. Then we'll give a short account about these lesions in the pediatric age group. These are the issues we would like to discuss, and this is a diagram which is very helpful so that you can appreciate the difference between the epidural blood and the subdural blood. The epidural blood has a convex inner margin, and it can cross the midline, and it is usually related to a skull fracture, and this skull fracture may be associated with an extracranial subgaleal hemorrhage as well. The subdural blood has a concave inner margin. It cannot cross the midline. It will go within the falx or the tentorium. It is not usually associated with fractures. Sometimes it is associated with fractures, but the subdural hemorrhage in the pediatric age group is usually related to trauma and may also be associated with skull fractures. Then skull fractures were diagnosed previously by the plain X-rays with some difficulties in misinterpreting a suture as a fracture. And now we use the multi-detector CT sometimes in diagnosis of these fractures by having the 2D or 3D reformatted images of the axial scans so that you can appreciate the difference between the sutures and the fracture line. And this is 2D axial and 2D sagittal images where you can see the difference between the suture and the fracture, and you can appreciate the full course of the fracture line across the skull tables. And you can also, of course, have the 3D images in color so that you are able to also discriminate between sutures and the fracture lines. And many times the skull trauma is associated with a collection of extracranial blood in the subgaleal area, which is known as the subgaleal hematoma. And this is, of course, different from the cephal hematoma, which occurs during delivery in cases of obstructed labor. But here you see a localized swelling related to the calvarial bones. The calvarium may be fractured, and this is in history of trauma is diagnostic of subgaleal hemorrhage. And the subgaleal hemorrhage may be associated with fractures, as you can see here, and may not be associated with fractures. And subgaleal the hemorrhage is this collection of blood overlying the calvarium. And of course, you know that you are able to see the fracture in the bone window images, as you can see in this particular end. Then the skull fractures may be depressed or comminuted like this one and may be associated with intracranial complications and may not. And here is an example of a comminuted fracture of the uh, uh, right parietal bone associated with small subgaleal hemorrhage, but the brain tissue underneath the fracture looks good. And the subcutaneous hematoma or the subgaleal hematoma may be associated, as I have said, with fractures or may not, and it may be associated also with intracranial complications and may not. And it is better to discriminate between sutures, which are usually bilateral and symmetric, from the fractures to have the 2D or the 3D reformatted images. As you can see here, this is a case of trauma with comminuted calvarial bone fracture, which is appreciated good in the 3D image. And of course, in the axial images, it is usually difficult to discriminate the sutures from the fracture lines. And also, you can see in the axial image the presence of the subgaleal hematoma. Brain contusion means that it is a cortical lesion which is the sequelae of trauma. And this lesion may appear hemorrhagic and may appear as a hypodense area of focal brain edema. And we have to say that this is we used to say that this is a hemorrhagic fracture whenever you see hemorrhagic contusion, whenever you see hyperdense blood foci within the affected area. But if you see hypodensity, and this is also a contusion, and it is also hemorrhagic, but the hemorrhage here is petechial hemorrhage, so that you cannot see by in the CT images. So if you are going to write a report or to answer in the exam, then if you see hemorrhage, you say this is hemorrhagic brain contusion. If you don't see hemorrhage and you say this is brain contusion, and you know that this contusion should be hemorrhagic, in spite of you don't see the hemorrhage in the scan. Then the hemorrhagic contusions are usually related to the site of trauma, which is indicated by the presence of a calvarial fracture like this one, and also the presence of a subgaleal hematoma localized at the site of injury. But you know that there is contusions which are known as counter coup injury. There is a frontal trauma and you got the injury in the occipital lobe. And this is well known in the clinical practice. Then, in cases of trauma, and you see a cortical lesion, which is a mixture of hyperdensity fresh blood and hypodensity brain edema, and this is hemorrhagic brain contusion. And this contusion may be associated with hemorrhage outside the brain tissue, like this hemorrhage in the falx cerebri. And you know, the hemorrhage in the falx is in the subdural space. There is no epidural space in the midline because there is no bone in the midline. The epidural space is present between bone and the dura. Then whenever you see hemorrhage in the falx, hemorrhage in the tentorium, then you know that this hemorrhage is located in the subdural space. And of course, you can appreciate that there is a swelling of the brain of the cerebral hemisphere, which is relatively hypodense compared to the normal one, and this is due to associated brain edema. And this is hemorrhagic contusion of the right parietal lobe. You see an area of mixed hypo and hyper densities representing the contusion. Also, you can see the subgaleal hemorrhage. And you can see the fracture with gapping edges, and there is some brain tissue herniation through the fracture line. Also, if you look carefully, then you can see blood in the falx and also along the inner table of the posterior parietal area, and this blood is located in the subdural space, as I have said, and in the coronal T1 weighted MR image, you can appreciate the subdural location of the hematoma. Then this is a traumatic brain injury showing bilateral frontal hyperdensities representing hemorrhagic brain contusions, a small hyperdensity in the posterior parietal representing also another contusion. Then outside the skull, then you see a large subgaleal hematoma. By MRI, if you use the gradient images, you can appreciate the presence of blood even in minute foci. And here you can see this is the appearance of the blood in the frontal lobes and the appearance of the blood in the posterior parietal lobe. And this blood is present in the tentorium, and you know that this should be in the subdural space. The contusion will appear mainly of low signal in the T1 and high signal in the T2, except the hemorrhagic component, which will appear according to the stage of the hematoma. So if you are confronted by a cerebral contusion and you are doing follow-up exams, this is the usual sequence of events. In the acute state, you can see a swelling of the brain tissue, diffuse hypodensity with foci of hyperdensity representing the hemorrhage inside the contusion. Later on, the swelling will start to regress, but you still see the hypodensity and the hemorrhagic foci. And finally, you got an area of damaged liquefied brain tissue representing encephalomalacia, and the development of hydrocephalus here is most likely related to the presence of subarachnoid hemorrhage at the time of injury. And epidural blood is a bleeding which is related to the inner table of the calvareal bones and is extending along the inner table of the calvarium. This hemorrhage has a convex inner margin, and this hemorrhage can, if it occurs near the midline, it can cross the midline to the opposite side, but usually it cannot cross the suture lines because you know that the dura is firmly attached to the suture lines. Also remember the epidural blood is usually associated with fractures. And the fractures may be associated with some degree of subgaleal hemorrhage. You know that the epidural hemorrhage is maybe due to arterial bleeding or venous bleeding, and the venous bleeding is more common in children. But of course, you cannot know whether this is an arterial blood or venous blood unless you have the follow-up scans, and you can see the progression of hemorrhage. This is a big epidural hematoma on the left side, having a typical appearance, hyperdensity related to the inner table of the calvarium with convex inner margin, and you see the significant mass effect on the ventricles. And this is also a good example of epidural hematoma on the left side with convex inner margin and compression of the left lateral ventricle with dilatation of the right lateral ventricle secondary to kink of its foramen of Monroe. Then epidural hematoma, as you can see here, this is a small hematoma, and you see the typical appearance with convex inner margin and the mass effect exerted on the ventricle. Of course, the traumatic insult may result in any of the previously mentioned lesions like the contusion, epidural or subdural hematoma, and also it may be associated with diffuse brain edema. Diffuse brain edema, you can see the diffuse hypodensity of the cerebral hemispheres, and also there may be attenuation of the ventricular size, and also there is loss of the gray-white matter interface. You cannot discriminate between the gray and white matter because of the diffuse swelling of the brain parenchyma. And this is a epidural hematoma in a child hit by a car. They see the typical appearance. There is a convex inner margin, and it is intimately related to the inner skull table, and is associated with a minor degree of subgaleal hematoma. As I have mentioned, that epidural hematoma can cross the midline, but do not cross the sutures. The meninges are usually attached firmly to the sutural line. Then you can discriminate between epidural hematoma and subdural hematoma by the appearance of the inner margin of the hemorrhage. If the inner margin of the hematoma is convex, then you are dealing with epidural blood. If the inner margin of the hematoma is concave, then you are dealing with subdural blood. The epidural blood is present in a tight space, so it cannot progress superiorly nor inferiorly, but it progresses in its middle aspect. Then you got the fusiform configuration. But the subdural space is wide, and the blood can progress overlying the convexity of the cerebral hemisphere, so it will have a concave inner margin. And the subdural blood cannot cross the midline because it will descend in the falx cerebri, while the epidural blood can easily cross the midline if it occurs near the midline plane. And the epidural hematoma has a convex inner margin like this one. It is almost always acute, and also the subdural hematoma is acute in the pediatric age group. But in adults, you can see what is known as the chronic subdural hematoma, as I will mention uh, uh, after that. Then the epidural hematoma is almost always acute. It is usually post-traumatic. There is a significant history of trauma. It can cross the midline. It do not cross the skull sutures. It can be of venous or arterial bleeding. Also, the epidural hematoma can be bilateral, and also the subdural blood or hemorrhage can be bilateral. And this is the frontal epidural blood on the right side and parietal epidural blood on the left side. Then here is a child hit by a television set, and he developed a skull fracture seen in the bone window image and an epidural hematoma extending along the surface of the cerebellum as well as the surface of the temporal lobe. There is some subgaleal hemorrhage as well. And this is two epidural hematomas on the same side. A small hematoma in the temporal area and a larger hematoma in the parietal area. Then if you follow the epidural hemorrhage, the hemorrhage in general, it starts by an evident hyperdensity in the CT scan, and by time, this hyperdensity will decrease until it became hypodense compared to the brain parenchyma. But because of the epidural hemorrhage is producing significant symptoms and evacuation is usually performed early before the hematoma became or proceeded into the chronic stage. But in the pediatric age group, there may be a chance for an epidural hematoma to resolve spontaneously if you have follow-up scans guided by the patient clinical condition. And this is an example. You see this fracture and the epidural hematoma on the right side and the fracture line in the bone window. Then the follow-up scan showed resolution, complete resolution of the epidural hematoma in 3 months interval. And this is the fracture, this is the hematoma, this is the follow-up scan, and there is complete regression. But if the hematoma is followed for about 2 weeks, you can see this appearance, which where the periphery of the hematoma starts to be hypodense and bordered by the meningeal cavern. And in most of the cases, we do not see this in the clinical practice since most of the epidural hematomas are evacuated immediately. But in the pediatric age group, if the hematoma is relatively small, then you can give the patient a chance so that the hemorrhage may resolve spontaneously. And this is a subdural hemorrhage in a female child who has fallen from a horseback. Then the blood is related to the inner skull table on the right side. It has a concave inner margin, and you see the mass effect exerted on the ventricles. And you should remember that blood extending within the falx and within the tentorium should be in the subdural space because there is no epidural space in the midline. And this is what we call subdural hygroma and hematoma. Hygroma means accumulation of CSF in the subdural space. You know, the CSF is present in the subarachnoid space, but in some cases of trauma, there may be tear of the arachnoid membrane, resulting in leak of CSF into the subdural space, and this will lead to the formation of the subdural hygroma, which is one of the traumatic sequelae. And the trauma also may cause bleeding in the subdural space or in the epidural space, but here you see the subdural hygroma, CSF-like collection, and the subdural hematoma as well. And this is a good example of a subdural hemorrhage, hyperdense collection related to the inner skull table with a concave inner margin. Then, after some time, maybe the range of 2 weeks, the hemorrhage will start to decrease in density. Then it will shift from hyperdense to hypodense, but at a time while while the density is decreasing from hyper to hypo, it will at a time appear exactly similar to the density of the brain tissue, and then it will appear isodense. The hyperdense hematoma is the acute one, and the hypodense hematoma is the chronic one, while the isodense hematoma is the subacute subdural hemorrhage. And we used in the era before MRI to inject contrast media in order to diagnose accurately this blood collection. And after injection of contrast, you can see that the cortical veins are displaced medially, denoting that this lesion is outside the brain parenchyma occurring in the subdural space. And of course, you can see the fracture line. And this is bilateral subacute subdural hematoma. The hematoma is not hyperdense, not nor hypodense. It is isodense, almost isodense to the brain parenchyma. And sometimes you can see what's known as sedimentation level, where the dependent part of the hematoma is hyperdense, and the anterior part of the or the superior part of the hematoma is hypodense. And this mixed density is usually referred to in the images as the subacute stage. This is a mixture of acute and chronic blood, so the diagnosis will be a subacute subdural hematoma, and you can appreciate the extent of this hematoma in the posterior interhemispheric fissure on the falx. Then by MRI, this is T1 and T2. You know that the subacute blood will appear bright in the T1 and in the T2 weighted image. But according to the stage or the age of the blood, then you can see this hematoma is bright in the T1 and less bright in the T2, and this is what we call early subacute subdural hematoma or intracellular methemoglobin. And this hematoma is slightly brighter in the T1 and also of intermediate signal here. It depends on the age of the hematoma so that you can see the appearance of hemorrhage. This is MRI T1 weighted image and T2 weighted images, and you see a big subdural hematoma showing high signal in the T1 and less signal in the T2, denoting the subacute hematoma or intracellular methemoglobin. Subdural blood, especially whenever it is large like this, needs surgical evacuation. And this is the subdural hematoma, big hematoma on the right side, and this series after surgery with complete evacuation of hemorrhage. Subdural hygroma will result from tear in the arachnoid membrane, and this will lead to leakage of CSF from the subarachnoid space to the subdural space. Then you got in the CT or MRI variable sized collection of CSF over the surface of the brain in the subdural space, compressing the brain parenchyma. As you can see here, this is massive bilateral subdural hygroma. And this is hygroma and the hematoma. There is CSF collection in both frontal areas and a small amount of blood in the left frontal area, denoting hygroma and hematoma. If the hematoma is in the chronic phase, it will appear black or hypodense to the brain parenchyma. Then how can you discriminate between hygroma and hematoma? Of course, the hygroma will show the CSF density, which will be more hypodense compared to the density of the blood. The blood, even in the chronic stage, it will not reach the density of fluid. Then you can see the difference between hematoma and hygroma. Then Post-traumatic, the patient may develop brain edema. We have three types of brain edema. The vasogenic edema, which is usually the finger-like surrounding the brain tumors and abscesses. The cytotoxic edema, which is usually located around the ischemic and the hemorrhagic insults. And this is an example of focal vasogenic edema around this lesion, which looks like a tuberculoma or a cysticercosis because of the cyst and the dot sign, and you see the edema around. But in cases of trauma, you may get diffuse brain edema like this, and you see diffuse hypodensity of the brain tissue. The cerebellum is not affected. And you remember in the first part of this talk, we talked about this appearance, which was a diagnostic of hypoxic ischemic encephalopathy, but you know that the history is very important. And this patient had a positive history of trauma, then you expect that you are seeing a diffuse type of brain edema. Also, brain edema may result from sometimes the drug overdose or anoxia before the development of true ischemia, and also in the shaken baby syndrome where the trauma is non-accidental and it may result also in diffuse cerebral edema. Then you look here for the normal scan. These are the ventricles, and you can see the white and the gray matter, and you can discriminate between both. But this is a traumatized brain with diffuse mottled hypodensity of both cerebral hemispheres, with attenuated appearance of the ventricle, with loss of the gray-white matter discrimination in most of the brain tissue. And you can see hemorrhagic foci and like this one, and there may be also hemorrhage inside the ventricle, and you can appreciate the presence of subgaleal hemorrhage on the right side. And this is diffuse brain edema after trauma. There is a swelling of the brain, loss of the cortical sulci and fissures, diffuse hypodensity of the brain parenchyma with loss of the differentiation between the gray and the white matter, as well as attenuation of the cerebral ventricles. And this is also a case of post-traumatic diffuse cerebral edema with the same findings: loss of the gray-white matter interface, effacement of the cortical sulci and fissures, attenuation of the ventricles, and this is post-traumatic. Also, brain edema may result from drug overdose. And here you can see the diffuse hypodensity of both cerebral hemispheres. There is some sparing of the basal ganglia. Then this is a brain edema also from anoxic injury, and you know that if this injury has been or the patient recovered from this injury, the edema will subside. But if the injury is persistent, then the edema will go into ischemia. And here you see diffuse hypodensity of the both cerebral hemispheres, attenuation of the ventricles, loss of the gray-white matter interface bilaterally. And subarachnoid hemorrhage is one of the sequelae of trauma in adults and also in the pediatric age group. Then for the diagnosis of subarachnoid hemorrhage, you see fresh blood or hyperdense blood in the subarachnoid spaces, including the basal cisterns, the fissures, the cortical sulci, and you know that hemorrhage in the pediatric age group usually lies posteriorly in the interhemispheric fissure, but this is not a rule. This is an example of subarachnoid hemorrhage, and you see the hyperdensity within the cortical sulci. And you may also see hemorrhage inside the ventricles. hemorrhage in the subarachnoid space, and also hemorrhage inside the ventricles, as you can see, this hemorrhage within the aqueduct and in the lateral ventricles as well. Then the last issue in this particular section is the diffuse axonal injury. And this is a major form of traumatic brain injury, although the finding on imaging may be subtle. Then this injury is a shear injury or shearing stress in the white matter. It will affect the axons of the neurons, resulting in classically typical or petechial hemorrhagic foci distributed in characteristic locations in the brain parenchyma. A diffuse axonal injury has a poor clinical outcome, and the lesions are usually very small foci of hemorrhage distributed in both cerebral hemispheres as well as in the brain parenchyma. And you see these are whenever you see a patient with history of trauma and you see this petechiae or minute foci of hemorrhage, and you know that this is acute or diffuse axonal injury. The typical locations for these petechial hemorrhages are the white matter of the superior frontal gyrus here, and the frontal and the temporal gray-white matter interface in these areas and above, the posterolateral aspect of the upper brain stem, and the region of the corpus callosum. These are the typical locations. So, with a history of trauma, and if you look here carefully, and you can see this focus of blood and this focus of blood. In spite of these minor injuries, the clinical presentation of the patient is not corresponding to these minor injuries. Then in many cases, you can see that the brain CT is normal at the presentation. Then after a follow-up CT scan, and you can see petechial hemorrhage in the characteristic locations. Petechial hemorrhages are seen in only about 20% of cases with diffuse axonal injury. And there may be focal hypodense areas secondary to brain edema. In spite, you cannot see the hemorrhagic focus itself. But with the use of MRI, you can also be able to detect the hemorrhagic foci which are not detected by CT scan. This is diffuse axonal injury, hemorrhagic spot in the temporal lobe, and another one in the high parietal area, and a third one in near the foramen of Monroe. And this is diffuse axonal injury with extensive hemorrhagic foci in both frontal, occipital, parietal, temporal lobes, as well as the development of intraventricular hemorrhage. Then the gradient images of MRI are helpful to detect these hemorrhagic foci. And if you look here, and you can see this hemorrhagic focus, which will appear like this in the FLAIR image, but you cannot see in the T1 weighted image. But in the diffusion weighted images and the T2 star or the gradient images, you can appreciate these minor foci of dark signal which represent the hemorrhagic lesions. And this is also a diffuse axonal injury with all these black structures represent the hemorrhagic foci in both cerebral hemispheres. And this is diffuse axonal injury with typical appearance on CT scan, hemorrhagic foci in some areas, and some of the blood which may be located in the occipital horn of the right lateral ventricle. Then the injuries are usually severe than that depicted by imaging. The clinical picture is not is not corresponding to the minor changes seen in imaging. The brainstem function is unaffected in these cases, so diffuse axonal injury is not or is rarely a cause of death. And this is the difference between CT and MRI. And in MRI, you are able to detect more hemorrhagic foci compared to the CT scan. In the CT scan, you see this hemorrhagic focus, and then there may be another one here and another one here. But all the black dots seen in this MR image represent the hemorrhagic foci. And also this is an example between comparing the CT and MRI. In the CT, you see the hemorrhagic focus in the midbrain. It is also seen here, but in the CT scan, you cannot be able to see these hemorrhagic foci in the temporal lobe. And this is also the appearance of diffuse axonal injury in the CT and in the corresponding MRI. And of course, you may be able to appreciate more hemorrhagic foci which are not seen on the CT scan. And also you can see the blood in the occipital horn of both lateral ventricles. This patient developed diffuse axonal injury after trauma, and he was on anticoagulant therapy. Then, being on anticoagulant therapy, he is liable to more bleeding. And this what happens in the second day of injury. The injury, the foci were small, then the follow-up showed more bleeding because of this anticoagulant. Then the prognosis is worse if the lesions are multiple and severe diffuse axonal injury rarely cause death, as I have mentioned before. 90% of the patient remain in a persistent vegetative state, while 10% of the patient return to the normal function within 1 year of the injury. Then finally, we would like to talk about the vascular intracranial lesions. We have discussed all these lesions previously: the aneurysms, the arteriovenous malformation, the cryptic arteriovenous malformation, the cavernous hemangioma or the cavernoma, the developmental venous anomaly, and the anomaly of the vein of Galen or vein of Galen aneurysm, and also the Moya-Moya disease. But I would like to emphasize these two important issues. Number one, whenever you see a bleeding which is not related to trauma in the pediatric age group, then you think of an underlying pathology. And the pathology underlying the hematoma is usually one of two: either the cavernous hemangioma or the venous angioma or an arteriovenous malformation. And it is easy to appreciate the hemorrhage by CT, and this is the usual way of investigation in emergency. You start by CT, then you see a hemorrhage in the cerebellar vermis, and this hemorrhage has extended into the fourth as well as into the lateral ventricle. There is no history of trauma, then you think of an underlying pathology. And the pathology is either one of two: the venous angioma or an arteriovenous malformation. Of course, in the cases of venous angioma or cavernoma, the follow-up scans and the MRI may help to predict the underlying cause after that. But in cases of arteriovenous malformation, an angiogram or MRI can, in most of the cases, detect the underlying abnormality. And this is the male, 18 years old, with a non-traumatic hemorrhage in the posterior parietal area. The cerebral angiogram confirmed the presence of an arteriovenous malformation corresponding to the site of the bleeding. Alhamdulillah Rabbil Alameen. Thank you very much.